Welcome to Eclipse the Wellbeing podcast, where well-being, culture, and technology meet real life. I'm your host, Chiamaka, and this is a space for honest conversations about health, identity, ambition, and what it really means to be well in our world today. Here, we unpack the apps, the algorithms, the cultural pressures, and the quiet truths shaping Black lives, especially Black women's lives. Let's jump in. Joining me today is Dr. Fred Boy. Fred is an associate professor with Swansea University. I'll let you introduce yourself, Fred.
Yeah, hi, Chiamaka. Hi, everybody. So I am Frederic Boy. I'm an associate professor in artificial intelligence and computational social science at Swansea University. And I am Chiamaka, PhD advisor, supervisor, I think we should say. And that's it. And I got super interested in what Chiamaka is gonna talk about today and explain us about a wonderful PhD project.
Yes, so absolutely, like Fred said, he's going to be in charge today and asking me questions about my PhD, and I will do my very best to answer those questions. I'm really excited. Yeah.
And Chiamaka, this is one of the first podcast. This is the first actually podcast we record.
Yes,
You've done
yes,
one just before, and so we are learning as we go. Uh, okay,
absolutely.
so and I'm sure we'll become better and better. Okay, so Chamaka, let's start with the elephant in the room. To start, can you briefly describe for our listener your PhD research and what you're trying to understand about women's health, well-being, and artificial intelligence and all this complex mix?
Okay, all right. So my PhD looks at how an inclusive AI-supported digital system can better support women at midlife. And I'm also looking at it from a Black woman point of view in particular. So, during that time, there's higher stress exposure, there's long-standing mistrust of health systems, and so that reflects even more during that time. So this research is going to ask the question how digital tools, including AI, can offer support that recognizes these realities rather than ignoring them.
Okay, it's pretty clear. But Chamaka, can you give us a specific example?
A specific example would be a woman, for instance, going through a diagnosis, or, my question is really whether there are things to support women and especially Black women during that time of their lives. So, midlife is a time when many women are experiencing ongoing health changes for the first time. There are hormonal changes during perimenopause and menopause that can increase the risk of heart disease, diabetes, gut problems, and low mood, essentially. And at the same time, women are also juggling work, they have caring roles. So for Black women, this period may begin earlier for them, perimenopause and menopause, and can be shaped by cumulative stress, racism, health inequalities. So if AI systems are built around narrow or average menopause timelines, for instance, they are likely to miss or misinterpret what the Black woman's experience is. The question is, are all experiences the same? And are there, systems to support women, all of the women going through those experiences, or should we be thinking more inclusively and answering the question whether we have to be, we have to think more, and do more for the Black woman.
So, Chiamaka, here you give me an opportunity because we are based in the UK, even if at the moment I'm in Colorado, but we are based in the UK where black people are a minority.
Mm,
So, when you're talking about, you mentioned average data, be- you mentioned something about AI system being based on an average data. What do you mean? Is it an issue that the health of black people wouldn't be as well documented as the health of the majority, just because data is data and there is less data on
mm.
black people? Is it?
Yeah, I believe that, from some of the research I've done so far, Black women are often underrepresented
Mm,
or misrepresented in health data, which means that AI systems may not reflect their real health experiences. This is especially at midlife because Black women are more likely to experience, like, for instance, early onset of perimenopause and menopause, often alongside higher levels of stress and existing health
mm.
inequalities. So, if AI systems are built using data that assumes later or average menopause, they may miss this. But yeah, I think from what I've seen so far, the Black women is definitely underrepresented and misrepresented in health data.
Okay, so you believe actually it's a great risk for AI system to be designed using actually what is a partial view of society.
Yes, yes. I believe that inclusive AI needs to
Mm.
take race, gender, and life stage seriously together. Otherwise, digital tools will risk reinforcing inequality. Mm.
Okay, and but why are women turning to digital tools, and what does that mean for inclusive AI? Why are women turning to tools that are actually not in-person
Mm. Yeah,
relationship?
I think women often use apps, online forums, and symptom trackers because they don't
Mm,
feel fully supported by healthcare services, I think, or maybe because these tools are out there and they feel that maybe they will get answers in a way from these tools that they don't get face to face from professionals. Perhaps they feel that maybe the tool speaks to them in a way that makes them feel that they feel more understood. These tools help them make sense of the symptoms or feel less alone because you can kind of go back and forth as much as you can with some of these tools. And maybe because there's no face, they feel much more comfortable as well. But from an inclusive AI perspective, this raises an important question, which is who are these, tools designed for? So even though these tools are available to them and women are turning to these tools, is it designed for them? And who feels left out from these tools? So if tools only work well for certain groups of women,
mm.
they may increase inequality rather than reduce it. So there's a risk there. Yeah.
But how do we ensure that women can know on which data the tool, the app, or the database, or whatever is based on?
Yeah, the tools that the AI is based on. Yeah, that's a good question. I know in some of the interviews that I've been doing with some health professionals, um, even they're not that close to data that is being used or captured for tools or how the tools are designed. They just use the tools that are available. So yeah, there's definitely a gap in understanding, or maybe there isn't a good level of curiosity to have made that information available to all of them, to everyone. But it's a good question. I don't know that women really understand the specifics around the tools that are available that are being used. But that's definitely one to take away. Mm,
Because looking at women's health is actually is important for women's health. Looking at black women's health is important to black women's health.
mm,
But your PhD also, in a sense, contribute to an ethical reflection on what we do with data, what we do with health, and really make a practical contribution to defining what inclusive AI
mm,
is. At the moment, everybody is talking about AI that must be inclusive, but what is it in practice? And I think we have here a case study of what it is in practice to be inclusive.
mm.
The, you know, uh, so how do you think your PhD could, because you're at the beginning, could contribute to inclusive AI? What is your dream?
Mm,
Your
mm.
dream contribution?
Yeah, you know, my dream. So I think what really triggered this and what raised my interest around this is the fact that um, women, especially those from marginalized backgrounds, are often missing from health data. So, and we,
Mm,
we we see that AI systems and tools are being trained on the existing data, which already excludes them.
yeah.
And so these tools may fail to recognize the real pattern or needs of everyone, including these women. Inclusive AI means actively addressing these gaps rather than assuming the data is neutral. So without this, digital tools can repeat same biases over and over again that women already face in the health system, in the healthcare system. So what I'm hoping to address is to address that gap, make my contribution towards including some of these women in the data that is captured for health tools, and hopefully reflecting this in a tool that takes them into consideration during, a crisis.
You're raising a very interesting point here because often we don't know on which data an AI system is based on. We don't know they call it the ground truth. We don't know what the ground truth is. We don't know how detailed it is. We don't know if as you say, a marginalized community is really taken into account.
Mm,
It's a data, it's a statistical problem. If you've got a little pocket of population with very specific characteristics, but which represent only a small proportion of the total population, well, it's going to be more difficult for a system to recognize
mm,
that there are specificities for a group at the margin. And here I'm using at the margin, which is maybe less connoted negatively than marginalized, but
yeah.
at the margin because it's a smaller ensemble of people that have shared characteristics. And it's often even a system that would be designed without bias will be biased because this small pocket of data
Mm,
isn't represented in the big one. Of course, if you start building on a real system that is biased, okay, the data doesn't exist. But even if the data exists, it is at the margin. It's a small ensemble of data, a
mm,
small pocket.
mm,
So it's more difficult. So I think we have to be aware of, and it's my personal opinion, we have already talked about that. I don't believe in kite mark.
Mm.
I don't believe in the unbiased, we are designing AI that is unbiased. Nobody can guarantee that. It has to be actively designed to address the fact that a small ensemble of grand truth representing a community with special characteristic must be processed separately. It must be addressed. There must be, how to say, it must be addressed voluntarily. It's a decision.
Mm.
It's why your PhD raised massive ethical question. Because it's a decision, it's the decision of a society to process specifically some data. And how it raises complex issues.
Mm.
But it's why, and it's what I like in your PhD, is that it raises a lot of ethical issues of
Mm.
data processing, of data ownership, of data collection. How do we collect data from communities, from specific communities? You know, maybe in the UK, we can ask for some specifics, or in the US, we can ask for, they use the word, in the Anglo-Saxon world, people use the word race. In Latin or Southern Europe, people will not use the word race. It's connoted as racist. So they, for instance, in my home country, I'm French, it is absolutely illegal to ask um, people cultural, religious, ethnic characteristics. It is illegal. That's why you can't count how many French people are black or of North African
That's
descent
very
or
interesting. I didn't know
yeah.
that. Mm.
It raises issues regarding the representativity of AI system. If you can't ask, you don't have the data. And if you don't have the data, how is the system biased? Well, toward the majority, of course, toward the mean. That's why when you talked about the average, yeah, this is the right term.
Mm.
The system will be biased toward what we call the central tendency, the most representative individual. But in the UK or here in the US, you don't have this problem. So maybe some question like your PhD can be asked.
That's right. That's right. I mean, I've heard of an example of an AI system or method that was used and I believe this was in the US, where they wanted to target patients that
Mhm.
they felt needed more care and
Yeah.
ensure that they get extra care.
Mhm.
But and so the data highlighted people who had used the health system the most. But what it didn't put into consideration are the people who couldn't afford to even use the health systems. And so the people who were targeted were the people who could afford it,
Yeah.
the wealthier ones, the marginalized group who couldn't even afford it in the first place were left out. So those are the kind of methods, we kind of need to be conscious of um, in AI and just make sure that we're using the right data and in design.
Yeah.
Exactly.
Absolutely. You're right. It's a question of design. It's a question of being open in the design to so in the design, in the data collection, in the at the very first point of design to be open to some questioning
Mm.
and to be open to real representativity of the population. So it's it's a common issue, and it's particular in health, and it's a common issue, and AI is incredibly marked, and the design in AI is incredibly marked by opinions, and even though the system will look scientific and based on math, opinions are dominating. Opinions and biases are dominating data collection. The system feeding into
Mm,
the AI.
mm.
So it's where maybe we have to work. But what would success look like for you at the end of the PhD? What would it be? It's
Okay.
a difficult question.
Yeah, that's a good one. I mean, for me, success would mean women feeling supported, all women feeling supported rather than overlooked. So, inclusive AI would help women understand what's happening, feel less alone while waiting for care, navigating health systems with more confidence. So, it would not promise quick answers, right? But it would respect women's experiences and support their well-being. That would be my typical inclusive AI tool. And so success for me would be any sort of contribution towards that.
Yeah. Wow. That's really ambitious, and it's what I love in your PhD is the ambition is here, and also because the need is here. The
Mm,
need is evident, and the ambition is there. So, Chamaka, I think for this first conversation, we have covered quite a lot, and from the practical realities, and it's important the practical to explain to the people the practical realities of AI and the part it plays in their health and in the monitoring of women's health. We've hinted at some ethical issues or ethical consideration that are central, some data collection consideration. And as you look back on this half an hour of conversation, what stands out to you? What
mm.
is the emergency? What is on your diary nowadays? What is
Yeah,
what people must act on now?
yeah. So for me, what feels most urgent is recognizing that women's well-being during midlife crisis is not a side issue. It's not. It's central. Because, we live in a culture where it feels like the older you get, the more to the side you're pushed to the side to the more. But no, women's well-being during midlife health crisis is not a side issue. It's central. And I believe that uncertainty, waiting, and distress are often treated as unavoidable, but they have real impact on health. So if people are building or using AI in women's health, they need to understand that these systems shape how supported or abandoned women feel. So the priority should be designing inclusive, ethical tools that respect lived experiences and support well-being rather than promising quick answers.
That's excellent.
Mm,
But then I'm jumping on a question.
mm,
Uh, it seems that what you say rests on actually educating educating the people about these issues.
mm.
Is it a program or something that we need to do? to communicate about that, to
I,
explain that?
oh, you just took the words out of my mouth, Fred. So I agree with you. I do believe that is a program that can be rolled out.
Okay, well, Chiamaka, this is fantastic. Thank you. I think we can bring this conversation at a close for today.
Yes, thanks so much, Fred. That
Yeah,
was awesome. Yeah.
thank you. Thank you so much.